Ladies and gentlemen, thank you for standing by. Welcome to the Emergency Preparedness and Response for Maternal and Child Health Population Conference call. During the presentation, all participants will be in a listen-only mode. If at any time during the conference you need to reach an operator, please press star 0. As a reminder, this conference is being recorded Tuesday, June 16, 2015. I would now like to turn the conference over to Megan Filippi. Please go ahead.
Thank you so much, Mary, and good afternoon, everyone, and welcome to the webinar, Emergency Preparedness and Response Resources for MCH Populations. My name is Megan Filippi, and I am a Program Analyst with the Women's and Infant Health Team at the Association of Maternal and Child Health Programs. Before we begin the presentations, I do have a few housekeeping reminders. Audio is available through your computer. If you're having any technical difficulties with your audio, please use the chat feature on the webinar interface, and AMCHP staff will be able to assist you. We will have time after the presentations for a question and answer period. We invite you to submit your questions throughout the call by using the chat feature in the lower left-hand side of your screen. Please send your questions to the chairperson, and please be sure to include to which presenter or presenters you are addressing your questions to. Today's webinar will be recorded. The recording and slides will be available on AMCHP's website after the broadcast. We will also be sharing it with our partners to distribute to their membership. Finally, you will receive a short evaluation survey after this webinar has ended. Please take a few moments to provide some feedback, as your input is very helpful in planning future events and learning opportunities. I will now turn it over to our moderator, Marianne Zotti, who will share our objectives for today's webinar and introduce our first speaker. Marianne, you have the floor.
Thank you, Megan. Thank you and welcome. We're just very thrilled that you're at our webinar called Emergency Preparedness and Response Resources for MCH Populations. The objectives for the webinar are to identify disaster effects associated with the health of pregnant and postpartum and other women of reproductive age, identify unique challenges that would arise for pregnant and postpartum women during an anthrax incident, and to discuss how the Reproductive Health After Disaster, or RHAD Toolkit, can be used to identify unmet MCH needs during the recovery phase of a disaster. So now we'll move to our first speaker, who is Ms. Sasha Ellington. She is an epidemiologist in the Division of Reproductive Health, or DRH, at the Centers for Disease Control and Prevention, or CDC. Her research areas of interest include infections during pregnancy, HIV, contraception, and emergency preparedness and response. She has published several peer-reviewed papers on these topics. Ms. Ellington recently led the maternal health team for the CDC's 2014 Ebola response and currently leads the Emergency Preparedness and Response activity in DRH. Sasha, please go ahead.
Thank you for that introduction, Marianne. Today I'm going to talk about strengthening emergency preparedness and response for reproductive health. Here is the outline for today's presentation. First, I will describe disaster effects associated with the health of pregnant and postpartum women and other women of reproductive age. Then I will discuss the purpose, role, and activities of CDC's Division of Reproductive Health, Emergency Preparedness and Response, or EPR, activity. And lastly, I will describe current EPR tools and upcoming activities. Pregnant women are cited as populations with special clinical needs, or at risk, in the 2013 Pandemic and All Hazards Reauthorization Act, or PAPRA. So what makes pregnant women at risk? Well, we know that for some infectious diseases, there is a disproportionate burden among pregnant women. For example, pregnant women may be at increased susceptibility compared to non-pregnant women for diseases such as malaria, listeria, and HIV. Additionally, pregnant women may be at risk for increased severity of disease once infected, such as influenza and measles. But we know less about the effects of disaster on pregnant women and reproductive health outcomes. Of the studies that have been conducted, findings have not been consistent and methods have varied widely. However, studies suggest that disaster exposure may be associated with poor reproductive health outcomes, including preterm birth or low birth weight infants, increases in pregnancy complications, increase in psychological stress, separation from family and other support systems, possible exposure to contaminants, and a loss of access to health care and medications. We really lack surveillance on pregnant women affected by disaster. This is partly due to pregnant women comprising just 1% of the general population at any given time. And this makes it difficult to collect meaningful information about them using traditional population-based post-disaster sampling approaches. The literature about disaster in postpartum women is even more scant. Let me go back one slide, sorry. But these factors were identified as affecting postpartum women after Hurricane Katrina. There was a lack of access to contraception and reproductive health care, lack of access to well child and acute care. There were effects on infant feeding for both breastfeeding and formula feeding, a loss of infant care supplies, an increase of psychological stress, and separation from family and support systems. Data about the effects of disaster on women of reproductive age are also very sparse. Disasters have been associated with changes in post-disaster fertility, but the associations have been inconsistent. In some studies, fertility increased, whereas in others it decreased. There is no routine surveillance of disaster-affected women of reproductive age. There are few studies on intimate partner violence during disaster. No increase in intimate partner violence was observed after the floods of Hurricane Floyd among adult women in eastern North Carolina, compared with rates of intimate partner violence before the disaster. However, multiple studies from Hurricane Katrina found significantly higher rates of intimate partner violence among displaced women in Louisiana and Mississippi after the disaster compared to both the national rate and the rate in the preceding 6 months. Even so, it was unclear if this was specific to women of reproductive age or for all women, as the average age for participants was usually in the mid-40s. Few studies have examined the impact of a disaster on women's access to reproductive health services. However, studies that do exist have found many women have difficulty accessing contraception during a disaster situation. Few studies mention access to other services, and if they do, the sample size is usually very small. So in May 2011, DRH started the EPR activity to better address the effects of infectious disease and disasters on MCH populations and reproductive health issues. The primary goal of the EPR activity is to build and disseminate the science around reproductive health and disasters and create tools for state and local public health partners. We have a web page on emergency preparedness and response for reproductive health, and I'll refer to this frequently throughout the presentation. We just updated this page yesterday with additional resources, and this is the screenshot of the new version. Additional information on many of the tools and activities that I discussed today can be found in this web page or through the links provided on the page. You can stay up to date by subscribing to the web page, which you can do by entering your email address in that upper right corner highlighted by the red circle. By subscribing to our web page, you will get an email whenever the page is updated and other email updates related to reproductive health and emergency preparedness and response. These are some of the EPR activities I will discuss today. The Pregnancy Risk Assessment Monitoring System, or PRAMS, preparedness activity, Anthrax Preparedness, the Strategic National Stockpile, or SNS project, and activation of the Maternal Health Team during the 2009 H1N1 response and the 2014 Ebola response. The first activity I'll discuss is the PRAMS preparedness activity. Our goal for this activity was to develop standard PRAMS measures that would increase our knowledge of preparedness behaviors among pregnant and postpartum women. There are now 4 optional questions on emergency preparedness available for PRAMS states. In 2009, Arkansas PRAMS was the first state to add an emergency preparedness question to their survey. From that survey, Arkansas found that among 1,173 postpartum women, 48% reported having an emergency plan. This was similar to the prevalence in the overall population. Other key findings included that Hispanic women were less likely than non-Hispanic women to report having a plan, and women with large families were more likely to have a plan. To our knowledge, this was the first examination of the prevalence of emergency planning in this population, and this paper lays the groundwork for why these analyses are important. We were able to leverage our existing resource, PRAMS, to help us address knowledge gaps in emergency preparedness among pregnant and postpartum women. So this comprehensive question on emergency preparedness is new and undergoing testing and programming, so it will be ready for use in the next cycle of PRAMS. The question asks women to answer yes or no to 8 questions related to preparedness planning. 2 states, Tennessee and Hawaii, have opted to include this new question in the upcoming cycle of PRAMS. We look forward to the increased knowledge on preparedness for pregnant and postpartum women that will be gained through this PRAMS question. In 2013, DRH completed an anthrax preparedness project. The purpose of this project was to identify vaccination and treatment issues related to anthrax in pregnant, postpartum, and lactating women and newborns. You will hear more about this in the next presentation. Activated by CDC's Emergency Operations Center, or the EOC, when pregnant or postpartum women have a significant need in a specific emergency response. During the 2009 H1N1 pandemic, it was recognized that pregnant and postpartum women with H1N1 influenza were at increased risk for severe outcomes. During the 2009 H1N1 activation of the Maternal Health Team, we created 9 maternal health guidance documents, addressed more than 4,600 inquiries, and published a supplement in the American Journals of Obstetrics and Gynecology in 2011 pertaining to lessons learned from the pandemic H1N1 response. For CDC's 2014 Ebola response, the Maternal Health Team was activated from October 2014 through February 2015. This outbreak is the largest response in CDC's history. Unlike the previous H1N1 activation, which was largely domestic, the Ebola activation of the Maternal Health Team included domestic and international activities. Domestic activities included developing guidance for U.S. hospitals, assessing hospital readiness for a pregnant patient suspected of Ebola, and providing technical assistance to state and local public health planners. While the Maternal Health Team is no longer activated, CDC's Emergency Operations Center is still activated for this response, and DRH subject matter experts remain available for scientific and technical consultations. During the activation, we developed 2 guidance documents on Ebola and maternal health. The first document was recommendations for breastfeeding, infant feeding in the context of Ebola, which was intended for international settings. The second guidance document was guidance for screening and caring for pregnant women with Ebola virus disease for healthcare providers in U.S. hospitals. This guidance is intended to help U.S. hospitals develop a plan for screening and treating pregnant women with suspected or confirmed Ebola virus disease. The team produced several publications and conducted presentations to disseminate the current knowledge on Ebola in reproductive health, and more are expected in the near future. Now I'm going to discuss some of the EPR tools that are available. They include the Reproductive Health Assessment After Disaster, or RHAD Toolkit, Post-Disaster Indicators for Pregnant and Postpartum Women and Infants, a pregnancy estimation tool, and an upcoming online training on the effects of disaster on reproductive health. The RHAD Toolkit was developed as a result of the gaps identified when we worked with the state health departments from Louisiana and Mississippi after Hurricane Katrina. The major gaps pertain to not having adequate sampling approaches for our populations of interest and not having pilot-tested questionnaires ready to use post-disaster. We worked with the UNC Center for Disaster Preparedness to develop a toolkit designed to give state and local health departments the information they need for local programs and policies to assist disaster-affected women. RHAD is a web-based set of tools designed to guide users through the planning, implementation, and analysis stages of conducting a reproductive health assessment after disaster. You'll be hearing more about implementation of the RHAD toolkit in a later presentation. Moving on, I will discuss our post-disaster indicators for pregnant and postpartum women and infants. The purpose of this activity was to develop a list of common epidemiologic indicators for pregnant and postpartum women and infants affected by disaster. Over a 12-month period, we convened a nationwide group consisting of 23 federal, state, academic, and other key MCH partners to actually identify or develop the epidemiologic post-disaster reproductive health indicators. The indicators are primarily to guide assessment and surveillance and affect public health interventions to disaster-affected pregnant and postpartum women and infants. Hence, wherever possible, the focus is on actionable items where public health programs, interventions, and policy can be used or adapted to meet needs. The final overall proposed list contains 25 indicators and their 90 measures for pregnant and postpartum women and infants and the accompanying set of questions. All are available online at the DRH Emergency Preparedness webpage. When conducting other post-disaster morbidity surveillance, you can use the post-disaster health indicators to collect supplemental information on pregnant and postpartum women. A sample protocol is available on our webpage, which shows how this can be done. I'd like to also take the opportunity to remind you of our Pregnancy Estimator tool. This tool is for estimating the number of pregnant women in a geographic area when there is an emergency. It can be used as a preparedness tool as well as when a response occurs. It is also available on the DRH Emergency Preparedness and Response webpage. Lastly, I would like to tell you about an online training we are developing for reproductive health and emergency preparedness and response. The training will provide information on addressing the needs of women of reproductive age during and after a natural disaster, bioterrorism events, and infectious disease outbreak, and how to find the tools and resources you need when a disaster occurs. The training will be available in 2016 through CDC Train. The website for CDC Train is provided here on the slide. Continuing education credits will be available for the training. If you sign up to receive email updates on our webpage, you will be notified when this training becomes available. If you would like any additional information on any resources or studies I discussed today, please do check our DRH EPR webpage and the reference list provided here. As I finish, I want to tell you that we always welcome input from you about your preparedness and response needs and information about how our tools and products work for you. Please feel free to contact us at any time at the email addresses here. Thank you.
Wonderful. Thank you so much, Sasha, for that informative presentation. I'm now proud to introduce Marianne Zadi, who is going to be presenting on behalf of Dana Meany-Delman. Dr. Marianne E. Zadi serves as a consultant to the Division of Reproductive Health at the Centers for Disease Control and Prevention. After 6 years as the DRH MCH epidemiologist assignee to the Mississippi State Department of Health, she became the lead epidemiologist in Atlanta on several reproductive health and disaster projects, including developing and implementing the Emergency Preparedness and Response Activity, the expert meeting to advise on updating anthrax prophylaxis and treatment recommendations for pregnant women, and most of the current DRH preparedness and response tools available for use by state and local health departments. Dr. Zadia has published many papers about factors affecting the health of women in crisis and their infants. Marianne, I will now turn it over to you.
Thank you. So I'm going to be talking today about the unique challenges of protecting pregnant and postpartum women during an anthrax incident. And I just wanted you to know that both Dana and Valerie had intended to be on this webinar, but both were called away to work on emergencies. So the focus today of this presentation is on intentional exposure to anthrax among pregnant and postpartum women and neonates, and how public health officials can react quickly in that public health emergency. This is particularly important because you don't normally encounter this exposure in your day-to-day work. So the objectives are to recognize the potential consequences for these women and their neonates, and then to help you to be able to find resources on how to provide post-exposure prophylaxis and treatment during an emergency. So what do we know about anthrax in pregnancy? CDC began a process in 2012 to update guidelines for prophylaxis and treatment for these populations in the event of an anthrax incident. And so we started with this question. During 2012, Dani Meany-Delman led a team in a worldwide comprehensive systematic literature review to describe the experience of Bacillus anthracis, or anthrax, in pregnant and postpartum women. Although the investigators identified 1,304 studies through 4 databases and 146 articles through cross-reference searches dating from 1886 through May 2012, only 14 articles met the inclusion criteria. Of these, 5 articles were translated from German and 2 from Italian. Overall, there were 20 cases. And of the 3 postpartum women, 1 was lactating at 5 months postpartum. The others were closer to delivery. All cases of anthrax were naturally occurring. Most cases were cutaneous. 3 were presumed to be inhalation. Most recent cases were from Turkey in 2003 and reflect a standard of care closest to the United States or the U.S. current system of care. They were cutaneous cases. Anthrax treatment for over half of the cases in this series did not involve antibiotics because they did not become available until the 1960s. In earlier cases, cautery, disinfectants, and even antiserum was used. Penicillin was the most common antibiotic used for treatment in the later cases. Depending on the type of anthrax, they were cutaneous, gastrointestinal, or uterine. These women presented quite ill with symptoms including fever, a black eschar or a dry, dark scab, or a falling away of dead skin tissue that comes from cutaneous anthrax, abdominal bloating, respiratory difficulty, vomiting, bloody diarrhea, and uterine hemorrhage. Mortality among these women was high as well. So you can see on the slide that of the 20 total cases, 16 resulted in maternal death, or a case fatality proportion of 80%, much higher than would be expected in the general population. However, this level of mortality occurred in the context of no antibiotics. In addition, we looked at the cutaneous case fatality proportion, which was 7 of 13, or 54%, which is much higher than the general population, where fatality is between 1% with treatment and 20% without treatment. The fatality proportion here for the untreated cutaneous infection is probably the most relevant and does appear higher than the general population. fetal death proportion was also very high at 65%. 11 out of the 17 pregnant cases resulted in a confirmed fetal death, and all these fatalities were associated with maternal mortality. In this series, there were no cases of fetal death when the mother survived. In 2 cases, there was documentation that the mother received antibiotics, but the currently recommended combination of antibiotics was not used in any of the cases of fetal and neonatal death. So here's an overall summary of the findings. So it shows the things that I've just talked about, but it also includes information on perinatal transmission and OB complications. And so if you go down to the obstetric complications, you can see that preterm delivery was reported. Labor coincided with presentation in 3 cases. Delayed diagnoses may have contributed to how severe the disease was. And in the perinatal transmission, 6 of 11 fetal or neonatal deaths demonstrated anthrax in the fetal tissues. But in 1 case, there was no evidence of passage of anthrax via breastfeeding. So that was a positive thing that we found. But over the story, the big story is that anthrax is a severe disease, and it can result in maternal and fetal death. It's unclear if the disease is more severe in pregnant women, but it's certainly as severe in them as in non-pregnant adults. The impact of antibiotic treatment on maternal and fetal outcomes is unknown. Penicillin was the most common antibiotic used for treatment in this series. However, the current treatment recommendation involves use of 3 antimicrobials. And remember that while most of the recent cases were from Turkey and are closest to the U.S. current system of care, they were cutaneous cases. In a bioterrorism attack, it is likely that most cases would be inhalational, which tends to be more deadly, and some may be cutaneous. Thus, outcomes in an attack might be more severe than those described in this review. Here you can see the sequence of activities that resulted in the recently updated guidelines for anthrax prevention and treatment among pregnant, postpartum, and lactating women. So in 2012, besides the review of cases that we just talked about, Dr. Meany Delman led a group of investigators who reviewed the safety and pharmacokinetics of 14 antimicrobials that are recommended for post-exposure prophylaxis and treatment in pregnant women with anthrax. These reviews laid the groundwork for the National Meeting of Experts, who reviewed evidence and provided expert opinions regarding key clinical elements of anthrax prevention and treatment among these women. The meeting summary was published to provide updated clinical information and guidelines to healthcare providers and public health professionals caring for these women in a bioterror event involving anthrax. And on the slide, you should note the Emerging Infectious Diseases link, or the EID link. That EID article also includes a Medscape CME quiz for continuing education credit for physicians. In addition, the updated guidelines were published. So we're going to be reviewing specific guidelines on the next few slides. The prophylaxis recommendations pertain to women who are exposed. Because of the severity of anthrax, exposed pregnant, postpartum, and lactating women should receive the same antibiotic dosing as non-pregnant adults, that is, a 60-day course. Ciprofloxacin is the preferred antimicrobial, and amoxicillin may be used for susceptible strains. Anthrax vaccine should be administered to both exposed and infected women at 0, 2, and 4 weeks post-exposure. This is the same recommendation as for non-pregnant adults. Infected, pregnant, postpartum, and lactating women, that is, those diagnosed with anthrax, should receive a combination of intravenous or IV antibiotics. Because of the concerns about transplacental transmission of anthrax, one of the IV antibiotics should cross the placenta. Now we're going to talk a minute about clinical considerations. Because pregnant and postpartum women experience normal physiologic changes that may make it more challenging to diagnose anthrax, the clinical considerations here are important because they may be the first signs of anthrax infection, or they may signal worsening health status. Therefore, epidemiologic data should include assessment of clinical signs, and clinicians need to be aware of the importance of these signs. Pregnant women infected with anthrax should be hospitalized and may require obstetric monitoring. And given the severity of the infection, hospitals caring for these women must be equipped for possible emergency deliveries. And lastly, if a lactating woman infected with anthrax wants to initiate or to continue breastfeeding, she may be allowed to, unless she has an active, untreated cutaneous lesion on her breast. Most importantly, if an anthrax biological attack occurs, go directly to this website that's on the slide. All the updated materials will be available to you there. And I wanted to end by showing you Dana and Valerie's contact information. I think it was also in the Pulse, and then mine is there as well. Thank you. And so now we are going to be moving. I see this. Yes. We are going to be moving to Dr. Mary Ellen Simpson, who will be doing the last presentation. Dr. Simpson is an instructor of nursing at the Graham Hospital School of Nursing and a clinical adjunct professor with the University of Illinois College of Medicine. She mentors the Rural Student Physician Program research projects and consults as an epidemiologist on several grants. Her major research topic areas of interest include improving birth outcomes and program participation in WIC and family case management, psychometric measurement of early intervention family outcomes, and the development of evidence-based services to improve the health of disaster-affected women and their families. Mary Ellen, please go ahead.
Thank you very much. Today I'm going to talk about implementing the RHAD toolkit that we heard about in the first presentation and improving MCH outcomes after disaster. In central Illinois, an unseasonably warm front produced some violent storms that resulted in an EF4 tornado on Sunday morning, November 17, 2013. Tornadoes create unique challenges. Four large counties were affected in our area, crossing the state of Illinois and into Indiana. The touchdown and lifting of the tornado would skip entire areas. The wind speed varied from EF2 to an EF4, all resulting in damage that was not uniform across the state. Graham Hospital School of Nursing began preparations to implement a study using the RHAD toolkit. And we used the Women of Reproductive Age Questionnaire on the website with modifications. Now, we recognize that reproductive age begins for women at age 15. However, due to IRB restrictions, our inclusion criteria was ages 18 through 44. Our initial plans were to collect data using EpiInfo 7. However, it requires an Android tablet that is larger than 7 inches. Thus, we resorted to the traditional paper and pencil surveys. But ideally, the use of tablet technology for input of the data reduces the data entry time significantly, and the data can then be uploaded from the field. We used a modified two-stage CASPER method with referral to gain access to those displaced from the tornado and for women who had lived in the affected blocks. This methodology is described in a paper by Horney et al., and also Marianne Zadi is an expert in this area. We superimposed maps of the affected areas with the U.S. Census Bureau data to identify clusters and then create maps. Now, the CASPER methodology, which is also on the CDC website, is used for areas where population is greater than 900 people. So this eliminated the rural areas in our study in the other 3 counties. Now, the city of Washington, Illinois was the only eligible area for using the CASPER methodology. And using this method, we described 30 clusters, and within those identified, so that was the first stage of the sampling, and then within that 7 addresses within that cluster were randomly selected. Then we created maps for the data collection teams that were going out into the field. And this is an example of one of those maps, and we found it extremely helpful to keep some of the other roads and streets that were leading in and out of that cluster. That became very important. As you'll see in this next slide of the before and after map, and you could see where on the right-hand side after the disaster that when we were out data collecting, it was very hard to even find neighborhoods or street signs. Everything was obliterated. So it was helpful. It was easy to get lost, and so those extra identifiers on those maps helped us see where we were at the time. Now, if you're partnering with an academic institution to implement the RHAD after a disaster, some of these following strategies might be helpful for assembling the data collection team. Graduate students or students needing a capstone project would be ideal. We went about recruiting volunteers to administer the survey in a number of ways. An article explaining the project and asking volunteers was included in our hospital newsletter. A poster was designed to explain the project and attract volunteers within the hospital, giving our message some visual impact. Press releases were sent to the area newspapers. We posted a number of progressively detailed Facebook messages seeking help on our Graham Hospital School of Nursing account, and we also posted to the Washington, Illinois Tornado Recovery Facebook account. We determined if any of our graduates living in Woodford or Tazewell counties, any of our graduates still lived in those counties, and we sent a postcard out to them asking for help with the project. We also sent out a mass email to our graduates employed here at Graham seeking volunteers. And then I also contacted graduates who had participated in a tornado disaster recovery effort following a 2012 tornado in Harrisburg, Illinois, and those people were also contacted. For training of our volunteers, we conducted training using the RHAD Toolkit handouts, and our sessions lasted a half a day, followed by role-playing. So the morning culminated in a safety briefing and a review of the completion of the tracking forms. Our data collection teams worked in pairs, and we also prepared handouts on referrals for the affected population. And this is a perfect time if you have a specific set of information or referrals that you want to design. This is a great place to be able to pass that out, to disseminate it. In Illinois, there is a, let's see, sorry, my slide didn't advance there. Sorry. In Illinois, a new 211 system is in place, and so we gave handouts to all homes about this service. 211 is a database where all services in the 4-county area are available, empowering the population to seek services and to help meet the needs of their families. And this is a copy of some of the handouts that we gave. In order to explain our presence in the communities, particularly during a stressful time, we tried to let residents know of our intent and that ours was a legitimate effort. By the time we went out to survey, more than 4 months following the event had occurred, and many people who were very suspicious of scams because there had unfortunately been scammers out there and trying to take advantage of them. The reason somewhat for the delay, too, I must add, if you remember, this tornado occurred the week before Thanksgiving. The following week it started to snow, and we had snow and adverse weather conditions for the next 5 months. And during the month of January and February, minus 30 and minus 40 were not uncommon. Again, there were press releases and an interview with myself published in multiple newspapers. We also prepared a statement explaining our mission and posted it on the school Facebook page and also on the Washington, Illinois Tornado Recovery Facebook page. We also linked to that document from the homepage of our school website. That way, when we talked to residents who were tentative about participating, we could reassure them by directing them to our official website and the posting of the project, thereby providing our legitimacy. Now I'd like to just take a couple minutes and tell you some of the lessons that we learned from this. In the RHAD toolkit, modify the questionnaire as needed. There was also a couple of areas that I had the following suggestions. If you want to assess change in consumption patterns of regarding alcohol and tobacco usage, you may want to ask both prior usage before and after the tornado if no other benchmark is available, and that way you can better assess change. The other area was on sensitive questions about sex, HIV exposure, and risky practices, sexual practices yielded us little information, and that might be better addressed in a different forum. Our initial data collection was in early afternoon following a morning of training. What we discovered is that most residents were not at home in the daytime, and it's a much more efficient use of resources for data collection teams to go out in the field late afternoons, evenings, and weekends. And data collection teams need to be available at these times. We had a lot of non-traditional students. Many of them are single mothers who have small children and also work part-time jobs. So it was difficult for many of those to be able to go out evenings and weekends. So that's just something you might want to think about when you're compiling your team. We attempted up to 3 visits at one address at different times of the day, night, or weekends. And on the tool referral sheet, we created codes to differentiate between not occupied and no one at home, and this facilitated our data collection teams to target homes for the second and third attempt when no one was at home to avoid searching for unoccupied homes. With the assistance of our local maternal child health coordinators, we were led to a Facebook page for a large apartment complex that was selected in the CASPER methodology. And although the health department couldn't violate HIPAA and tell us about the women specifically, they did verify the source of the apartment's social media page that provided a communication network for a group of Washington residents who were all displaced from their one large apartment complex. So we were able to post to that Facebook page and reach eligible women for participation in the study, and then we were able to link that data back to the appropriate cluster. Due to the difficulty locating our targeted participants, we spent about 2 months collecting data. But here are some strategies that might expedite reaching displaced women and their families. Through Facebook pages particularly, we learned about community dinners and block parties that were sponsored by area churches for various affected neighborhoods. And also, since the tornado struck on a Sunday morning when many of the residents were in churches, the churches themselves and their Facebook pages were also an avenue of communication and contact with the victims. While we didn't recognize the importance of donation centers, many women and children were dependent on those donation centers for help and support the first few and even later months. And Washington, Illinois also had town hall meetings to disseminate news and services and to give residents a chance to voice their problems and issues. And we had a plan to attend and set up shop to interview or to schedule interviews for interested participants. Unfortunately, we were later discouraged from that opportunity by the mayor and city planner for fear that it might be disruptive to the meeting. But these are the type of venues that would be where you have an entire neighborhood that's been displaced coming together again post-disaster, and might be an opportunity for reaching eligible participants. And then you can link that back to the cluster. And another important lesson we learned is to look for multiple Facebook pages. We had pinned all our hopes on the Washington, Illinois tornado recovery page. Little did we know that many groups created their own pages with their own focus, all of them relevant, all of them connecting victims, services, supplies, and support. If we had been aware of all these Facebook groups from the beginning, we could have reached far more people in a much more timely manner. It was a huge help in locating displaced women, and again, to locate those living in that specific cluster or neighborhood. However, when scheduling phone interviews, it is important for the interviewer to obtain both their current address, because for participants, we sent a $20 gift card, so you need their current address for sending that gift card, but you also need what their previous address is so that you can link that to the correct cluster. And those addresses need to be recorded on the questionnaire and the tracking sheet so that you can appropriately weight the data. In summation then, the RHAD Toolkit can assist our state and local MCH leaders to identify short and long-term service gaps and to help families recover from an emergency situation. The information gathered can help and evaluate your rapid needs assessments and your immediate response efforts, which we found were very adequate and most favorable. But the RHAD is also a valuable tool to identify the unmet maternal child health needs during the recovery phase of the disaster. And the RHAD findings can inform state and emergency planning and strengthen preparedness and recommendations. And ultimately, the results help support the development of evidence-based services to improve the health of disaster-affected women and their families. And here is my contact information, and I would be happy to share a copy of our report and our technical report and results, or to discuss with anybody that's thinking about implementing the RHAD toolkit. If there's any suggestions that we can help with, certainly be very happy to do that. and appreciate the opportunity to present to you today. Thank you.
Okay, thank you, Mary Ellen. That was very informative. And I want to thank all of our presenters. And right now we're open to questions. And I think that you're supposed to type them into the questions section, or actually, Megan, you might help with this.
Sure, I'd be happy to. So if you have any questions, please feel free to enter those into the chat box on the lower left-hand side of your computer. Thus far, we have gotten a lot of questions about if this webinar will be recorded and if slides will be available. The answer to both is yes. We will be posting these on the AMCHP website within the next week or so, and you'll get an email following the broadcast with a link where you can access those resources. So I'll give folks a few minutes. If you'd like to enter your questions into the chat box, we can flag those and direct them to the appropriate presenters. Okay, so we do have a question that came in from Tamara Dowie, and I apologize if I pronounced your last name wrong. How is this being implemented in Broward County? I believe that's in Florida. Will 211 Broward be used as a resource? So if any of our presenters have any information on Broward.
I don't. This is Mary Ann.
Well, this is Mary Ellen. It was 211 was new for us in Illinois, and it is just coming to some of the counties. So luckily for us that the counties affected were all we were able to use. So maybe my suggestion might be for Broward was to contact the Florida State Health Department or Emergency Response to see if they have that up and going for the state of Florida.
Great. Thank you, Mary Ellen. Then another question came in from Ryan Parks. I believe this is also for you, Mary Ellen. Did you have anyone monitoring all the Facebook groups to make sure that no false information was being passed along?
No, that's a good point. No, I had the help that I had from faculty and staff here. Our librarians were very helpful in monitoring the Facebook pages, but in trying to make sure that the information about our study and to help provide legitimacy was available. I think they did try and read through some of the Facebook pages, but as far as specifically monitoring everything, I don't think that happened. But we didn't seem to have any problems with that information.
Okay. And then another follow-up question for you. Is there any particular reason you did not use Twitter for your work in Illinois? Probably because the main researcher, myself, isn't Twitter savvy. And, I think what I was trying to say in this is that I think you're probably spot on. We need to think about using technology for reaching displaced people. And we really started out knocking on doors and soon realized that there weren't doors to knock on. And what was left were, people that were affected but not nearly as adversely as those that were completely displaced, and those are who we wanted to reach. So I think that's an excellent idea and probably something that should be considered for the future.
This is Mary Ann, I'd also like to say something about that. Mary Ellen really is the first, her project was one of the first ones that I felt like tried to deal in a really creative way with displaced women, and it's very difficult. First of all, it's hard to find these populations, and then secondly, just in normal times, and then especially when they're displaced. So I think we're just in the very beginning of figuring out kind of how to do some of that.
Yeah, the other thing is, and thank you, Marianne, for adding that. I guess the other point I want to say is that we were trying to scientifically use our sampling methodology, and we didn't want just a convenience population of respondents.
Right.
That would give us a better, stronger emphasis on our data. So trying to marry the two is something that I'm sure we can still improve upon.
Right.
And then Sasha, I think this is in relation to your presentation. What other states are implementing the PRAMS question related to emergency preparedness in the next phase of PRAMS, or if any of our presenters have any other ideas of other states that are implementing that question?
Hi, yes. So Tennessee and Hawaii are the states that are implementing it, and those are the only two states that are planning to implement that in the next phase.
Okay. Thank you. Are there any recommendations to share with pregnant, postpartum, and lactating women in rural areas with limited resources in preparing for a disaster situation?
This is Marianne. I would like to refer you back to the Pulse article by Jen Fidner in Pennsylvania. And you might really follow up with her in terms of, because what they did is they incorporated preparedness into their home visits. And we didn't have her present here today, and I've only talked to her a little bit, so I couldn't adequately describe what they do. But I think that they may have some really good ideas, and you might want to follow up with her.
Great. And we'll also, when we post the recording, we'll link to that special edition of the Emergency Preparedness Pulse, which is kind of the precursor for this webinar, so you guys can have that as a resource as well. Will the CDC be offering any training opportunities for Department of Health and Human Service staff and others throughout the U.S. to best prepare us for a local catastrophe?
So,
go ahead. Go ahead, Sasha.
I was just going to refer. So, the main training that we'll be offering is the one that's coming in 2016, which will be available to DHHS staff and everybody on how to prepare for for reproductive health needs during a disaster. Do you want to add anything, Marianne?
No, just that it's going to be available on CDC Train, and that means that it is available to anybody across the U.S.
And then just a quick question. Would you please repeat the woman's name who incorporated emergency preparedness into home visiting?
Her name is Jennifer Fidner. It's Fiddner, and she's from Pennsylvania. And as Megan said, that she will put up the link to the recent Pulse that related to emergency preparedness and response. And so you'll be able to see her picture there, and she describes their project there. And I believe there's maybe a way to contact her through that.
Okay, great. And then we'll take one last question. This looks like it's kind of targeted to me, actually. I'm very interested in any related MCH topics. How can I attend other conferences in person to learn a little bit more? So AMCHP hosts their annual meeting every year in January in Washington, D.C. If you go to our website, there's some information about our conference on there. Also, another MCH-focused organization is City Match, and they work with urban, local, and county health departments. And they host a conference, I believe that's coming up in the end of September in Salt Lake City, Utah. And if this individual is interested in learning more, please feel free to email me, and I would be happy to share that information. So with that, I would like to thank everyone for joining us on our webinar today. We hope you found this information to be valuable. Again, the webinar was recorded, and a link to the recording and the speaker slides will be posted on the AMCHP website within the next week. You'll be getting a direct link to where this will be located on the website in a post-webinar email. Please also complete the brief survey that will be emailed to you so that we can inform future learning events based on your feedback. I would like to thank all of our presenters for their willingness to share not only their time but their expertise with us today. So thank you so much for those informative presentations. And I would like to thank everyone for taking the time to attend today. Have a great rest of your day. Operator, you may now conclude the broadcast.
Thank you.